Hi, I'm Dr. Erica Spatz. I'm a deputy editor at JACC, and today I'm joined by Dr. Anand Vaidya, who is a endocrinologist and director of the Center for Adrenal Disorders in the Division of Endocrinology, Diabetes, and Hypertension at the Brigham and Women's Hospital. Anand, welcome to JACC, and thank you so much for your commentary on primary aldosteronism that relates to the new 2025 high blood pressure guidelines. It's a pleasure to have you on this podcast.
Thanks for having me, Erica, and it was a pleasure to write the commentary.
So Anand, I trained in the early 2000s and always learned about hypertension as essential or not due to another underlying condition, and then all of the long list of secondary causes of hypertension, among which primary aldosterone is one of them. And your piece suggests that maybe we should start thinking about primary aldosteronism as something potentially in the liminal space between primary and secondary. What's causing the shift around aldosteronism?
It's a great question. I probably trained around the same time as you, and so much of our understanding about the mechanisms and causes of high blood pressure have changed, evolved, even rapidly modernized. But I think it's hard to convey that knowledge to practicing clinicians because that original tutelage that we had is hard to let go, kind of unlearn, and then relearn a new model. I personally do not like the terms essential hypertension or even idiopathic hypertension or primary versus secondary, because it implies that there's an other. Sometimes people use endocrine hypertension, secondary hypertension. I think about hypertension as elevated blood pressure, and there are many reasons why even one person can have elevated blood pressure. It's almost a syndrome or a constellation of things that causes a phenotype, high blood pressure. One can, for example, be obese, have sleep apnea, drink too much alcohol, and not exercise, and eat a lot of sodium. All of these factors contribute to their high blood pressure. All of them are modifiable factors of high blood pressure. And so I would think about primary aldosteronism as the same, having too much or autonomous or dysregulated aldosterone being produced, increasing sodium retention and volume expansion from kidney mechanisms, maybe even direct vascular fibrotic issues is another mechanism that contributes to high blood pressure, and it is modifiable. So what that means is if you address somebody's aldosteronism, that's not going to cure their hypertension. It's not a one-to-one relationship. It's one modifiable contributor to their high blood pressure. And the reason it's important to think about it that way is all of these factors that I've just mentioned are very common in modern industrialized societies. And so too is primary aldosteronism. And that has really come through, if you'd like me to discuss it, in modern studies that have started to evaluate how common primary aldosteronism is and have been kind of shocked that it has overturned the traditional or classical model of how common it was.
You note in your piece that primary aldosteronism may account for up to 25% of all cases of hypertension. I mean, that is huge. And yet, when I think about my patient population and their responsiveness to mineralocorticoid receptor antagonists, the MRAs, I start to think, well, maybe they are so responsive because they have underlying aldosteronism that I've never diagnosed. Is it up to a quarter of people may have primary aldosteronism?
Yes. So yes, it's at least a quarter of people, particularly with resistant hypertension, have primary aldosteronism, pretty clear primary aldosteronism. The number who have a form of aldosterone production that is probably pathologic far exceeds that. So another way to say it is aldosterone-mediated hypertension is probably much higher. And you can kind of see that in the kind of recent flurry of phase 2 aldosterone synthase inhibitor trials that have been published all over in the last 1 year, which I won't get into, but essentially they kind of show that if you reduce aldosterone production, blood pressure goes down in a lot of people without even knowing what the underlying pathology is. But I'll focus on primary aldosteronism. Jerome Kahn described this syndrome in the mid-60s, and it was in the most extreme case, a woman with paralysis from severe hypokalemia who had an adrenal adenoma making tons and tons of aldosterone, causing high blood pressure and severe hypokalemia. And so that Conn's tumor or aldosterone producing adenoma is burned in everybody's head as this extreme phenotype of the disorder. And that's what most people learn about in medical school. And that does exist, but it represents the very tip of the iceberg, the minority of all cases. The majority of cases of primary aldosteronism are much milder and just look like run-of-the-mill hypertension. There are no symptoms, there's no hypokalemia, there's even mild or moderate hypertension, not even resistant hypertension. So the question then is, how do you distinguish those individuals? And that gets to the biochemical phenotype. The biochemical or hormonal phenotype is a suppressed or low renin, and therefore a low or suppressed angiotensin II. And in that condition, aldosterone should also be low, but instead it is not low. The adrenal glands continue to spit out and produce aldosterone, even though the renin-angiotensin II axis, which stimulates aldosterone, is turned off. That's the biochemical definition of primary aldosteronism, and then that creates a vicious cycle of volume expansion, further renin and angiotensin II suppression, more aldosterone, and so forth. And if you start scanning for that phenotype, as studies have done in the last 20 years, more so in the last 10 years, and exceptionally in the last 5 years, you find that at least a quarter of people with resistant hypertension meet that criteria overtly. You can make arguments because we don't have a gold standard to validate the definition of where to draw that line. Is it 20%, 25%, 30%? You can go higher, but the point is it's a lot. And if you take a more liberal standpoint, you might say all individuals with low renin hypertension have some degree of primary aldosteronism. And indeed, in studies of low renin hypertension, MR antagonists seem to lower blood pressure across the board, somewhat proportionally to how much aldosterone they make. So you can even say the question you're asking is really, well, how do you define primary aldosteronism? And that may not be ultimately what's as important as saying who will respond to aldosterone-directed therapy. So you can almost create different schools or philosophies of thought. Do we need to define primary aldosteronism, make it a thing, and then treat it? Or do we work off of the clinical outcomes that are achieved by treating aldosterone-directed hypertension or cardiovascular disease or X? And I think the cool part of the time we're living in right now is both of these things are happening at the same time. And I suspect in the next 5-10 years, they will all converge on what's best for the patients. And the definition may matter less than what the outcome is.
So as a cardiologist, when the potential for secondary causes of hypertension come up, we break a sweat. What's involved, right? What medications do I need to stop? Do I need to salt load to test for primary aldosteronism? I was pretty excited to see the new high blood pressure guidelines really embrace a very simplified approach to diagnostic testing that even cardiologists can do.
Yes.
And you also compared those recommendations with that of the Endocrine Society. And I wondered if you could elaborate more about what is the diagnostic approach to somebody who you suspect has primary aldosteronism?
Yeah, it's a great point. And I will just say it's not just because you're a cardiologist. This is true across the board, which is that the approach to working up primary aldosteronism has been so intimidating that the uptake rates of testing have been approximately zero. So you could walk into my hospital, Brigham and Women's Hospital, a tertiary care, large academic hospital that's full of people who follow the evidence, and the number who follow the guidelines, the older guidelines that recommended testing everyone with resistant hypertension, everyone with hypertension, hypokalemia, is about 1%. You can go to any academic center in the United States, it'll be 1%. You can go anywhere in the world, it's a very reproducible statistic, it's 1%. So in other words, the guidelines say screen 100% of these folks, the uptake is barely 1%. Okay, so it's about zero. And the main driver of that, it's not just education, it's not just awareness, it's just intimidation. All this talk about what time of the day, which medications do I need to stop? What if I do the test and then I get the results? I don't know how to interpret the test. It has really spooked people out. So these new guidelines have actually simplified things. And it's partially due to the recognition that primary aldosteronism is far more common than we thought, and that barriers need to be removed so that people even undertake the testing. So the new blood pressure guidelines have effectively expanded the population eligible for testing based on what you just said, that up to a quarter of people can have primary aldosteronism? Yes. So then you need to scan and test in those individuals. So the new guidelines recommend all patients with resistant hypertension, uncontrolled or stage 2 hypertension. The Endocrine Society guidelines go even further and say everyone with hypertension. Now, if only 1% are being tested now in the high-risk group, you can imagine that the uptake will still be suboptimal, but hopefully it will increase. The other thing these guidelines do, both the Endocrine Society and the ACC/AHA guidelines, blood pressure guidelines, is to say, like, you don't have to think too much. Just measure a renin, an aldosterone, and a potassium. Right then and there in your clinic. Ideally, these hormones are better measured in the morning after stopping interfering meds, but you don't have to do that. In fact, I would recommend that you do it right then and there in your clinic for a few reasons. One, you will get the test if you don't send your patient away. And two, testing on medications, if anything, is a stress test for the diagnosis. Most medications, the problem is false negatives, not false positives. Most medications that patients with high blood pressure are on raise renin and lower aldosterone. So an ACE inhibitor or an angiotensin receptor blocker will raise renin and lower aldosterone. If you end up with a biochemical phenotype of renin-independent aldosterone production, despite a medication like a RAS inhibitor, you've proven that your patient has primary aldosteronism by doing no work. You have not stopped anything. You have not changed anything. Right? Thiazide diuretics, all diuretics raise renin. MR antagonists raise renin. So in my opinion, you should stop nothing. On the first screen, just go ahead and measure. You might get your answer right then and there. And if you don't get your answer, you can consider whether you want to wash medications off, repeat tests, refer the patient to a specialist that you trust, or just treat them with an MR antagonist, which is another approach that has been highly recommended. These are highly effective, generic drugs that are associated with good outcomes and severely underutilized. It's almost never wrong to say, maybe I should just put this person on an MR antagonist. It's a better approach than what's currently happening, which is a gross underutilization of these highly effective medications.
Thank you. That is terrific. Really simple. I love it. Now, do all of my patients who have the diagnosis of primary aldosteronism need to be evaluated for an adrenalectomy? And how do we know who should be referred for further testing?
Yeah, this is a great question to which a perfect answer does not exist, but I suspect in 5 to 10 years from now it will. And this is another bottleneck. So as you mentioned, a minority of individuals will have what we call unilateral or lateralizing primary aldosteronism, meaning it's predominantly coming from one side. You don't need to have an adenoma, I should just say, okay? Like if you do a CAT scan or MRI and the adrenals look, quote, normal, that's fine. The sources of aldosterone production are usually microscopic. You need immunohistochemistry to see them. You don't need to have an adenoma at all. If the primary aldosteronism is coming mostly from one side, an adrenalectomy can be offered. You can cure or abolish most of the pathologic aldosterone production, and you only need one adrenal gland to function normally. But the vast majority of individuals will have non-lateralizing or bilateral primary aldosteronism, which will be treated medically, for example, with an MR antagonist, with encouraging dietary sodium restriction, and so forth. So the question is, who is going to have unilateral and bilateral? Because to get to the unilateral diagnosis, you need to do adrenal venous sampling, which is one of the bottlenecks. It's a highly specialized procedure that requires an experienced interventional radiologist and so forth. And we don't have a perfect predictor. Okay, there is no single biomarker. People are working on it. There's novel PET imaging techniques that people are working on, but are still mostly at the research grade level that are not available to most clinicians. And so unless you work in a high volume center where you have easy access to adrenal venous sampling, you're going to have to make a choice. You have to talk to your patient, look at your resources, look at the socioeconomic status, look at the distance to the closest referral center that can do high quality adrenal venous sampling and decide whether it's feasible or not. Either way, mineralocorticoid receptor antagonists at minimum are implicated for your patient, right? So a key point here is it's not that you don't have any options. You have an option. The only question is, can you get to an even better option? Because a curative surgery is often associated with better outcomes than lifelong medical therapy. So you don't want to prevent that option for a patient who can get it. But if you don't have that option, if it's not feasible financially, geographically, realistically, at the minimum, start your patient on an MR antagonist. And the people who are more likely to benefit from an adrenalectomy are those who have a higher and longer exposure to pathologic aldosterone production. So the younger the patient, the more you want to push to see if you can get adrenal venous sampling done. The more severe the primary aldosteronism, the greater the potential benefit of a surgery might be. But remember, in the end, most patients, even after adrenal venous sampling, will end up having non-lateralizing disease that is going to be treated medically.
Fantastic. Okay, my last question. My patient is diagnosed. They are on an MRA and I am managing them. What should I follow? How do I know that I'm addressing the underlying problem?
First and foremost, blood pressure. As the blood pressure guidelines tell us, the most modifiable and important risk factor is blood pressure. And so blood pressure control is number one. And I think what's important here, not just for cardiologists, but all specialists, MR antagonists are not a one and done thing. So in some other cardiovascular indications for MR antagonists, like in heart failure, a single dose is what has been studied, and that's what's been prescribed. But in primary aldosteronism, the correct dose is the right dose for the patient. And so what I would recommend is you start low, say, for example, 12.5 milligrams of spironolactone, or 25 milligrams twice a day of eplerenone, since it's a little weaker and requires twice daily frequency. Encourage dietary sodium restriction. This really creates a synergistic effect of blood pressure lowering. And then follow the blood pressure, and you have to up titrate the medication. And the goal is not only to get blood pressure into the quote normal or optimal range for your patient, their background disease, age, etc., but by also consolidating their other meds, reducing polypharmacy. So if they were on 5 antihypertensive medications and you can get them onto 3 by up titrating spironolactone or eplerenone, that's better. If your patient is one of the minority who also had hypokalemia, you want to correct the hypokalemia with the MR antagonist without the use of potassium supplements. And if you achieve those two, that's 90% of the game. What more recent studies, mostly observational studies, but many of them have shown is that if the renin goes from being low to high, suppressed to unsuppressed, as a kind of a biomarker, that you've adequately blocked all the MR such that the renin-angiotensin system has risen again, that's associated with better outcomes. So the endocrine society guidelines recommend these 3 goals. By far and away, blood pressure control is number 1, ideally with the fewest medications. 2, if applicable, correction of hypokalemia. And then once you've achieved those, has the renin moved from its baseline upwards? We don't know what threshold or if there is a threshold, but the fact that it rises is an endocrine forward feedback that tells us that we've blocked the peripheral receptors and we've reversed the underlying pathophysiology of primary aldosteronism.
Thank you so much, Anand, for these incredibly helpful tips for our community of primary care, cardiology, nephrology, endocrinology clinicians, because I think the lessons that you've described in your commentary, what we've discussed today, and that appear in the proposed algorithm are going to do a lot to change clinical practice, and with the ultimate goal of controlling blood pressure and improving cardiovascular outcomes for our patients. So I'm so grateful for all the time that you spent with us today. Thank you so much.
Oh, thanks for inviting me, Erica, and I'm really glad that JACC is spotlighting this very important issue.